Welcome, ladies and gentlemen. I'm Dr. Silva. Thank you for joining me. Today, you're in for a treat. Today, I'm going to talk to you about Xanax and Xanax XR, what they have in common, how they differ, and which one might be right for you. Obviously, they're both alprazolam. Alprazolam is a benzodiazepine, or benzo for short. Benzodiazepines are positive allosteric modulators of the GABA receptor. GABA is gamma-aminobutyric acid, the major inhibitory neurotransmitter in the central nervous system. GABA is an endogenous neurotransmitter. It's not a medication itself. So when GABA acts upon its receptor, things get dialed down. You relax, anxiety dissipates, it functions as an anxiolytic or anxiety buster. At higher doses, medications that increase GABA, GABAergic medications, cause sedation. They're sedatives. The same anxiolytic medication at a higher dosage is a sedative. At yet higher doses, the same GABAergic medications function as hypnotic agents, i.e., they induce sleep. They're sleeping pills. These medications are classified as sedative hypnotics, as in sedative hypnotic use disorder, because they're also habit-forming. They can be addictive. So, 3 dose-dependent functions on a spectrum of intensity: anxiolytic, sedative, and hypnotic, in parallel with escalating doses. And the threshold for each of these, that is, the dose necessary to produce these effects, depends upon a person's tolerance, which goes up with continued use. This is why they're habit-forming, and why you can go into withdrawal. It also depends upon a person's body weight and how they absorb and metabolize medication based on genetics and a host of other physiologic variables, if we're comparing across individuals. But in any given individual, it's mostly about tolerance. So that's what happens when you increase GABA, or when GABA binds to its receptor with greater frequency. It calms you down and maybe makes you sleepy. By the way, tolerance develops fairly rapidly to the sedative property, but not the anxiolytic property. Relatively small initial doses work pretty much indefinitely to prevent panic. We don't need to keep escalating the dosage just to keep a patient calm. I talk about that in other videos. Some of my colleagues may disagree. Certainly at the very lowest doses, you may need to titrate the dose a little bit to maintain efficacy in terms of anxiolytic efficacy, but you don't need to continue to increase and end up on a ridiculous number of milligrams every day to prevent panic. So you might take the medication and eventually not feel sleepy at all, and so it's not working anymore as a sleeping pill. But as far as preventing you from having a panic attack, you're not going to have a panic attack on a milligram of Xanax. A milligram of Xanax, you're going to be pretty calm. In toning things down, you also get an increased seizure threshold, meaning it takes more of a stimulus to cross that threshold, to induce a seizure. Various things, including substances, can lower that threshold and cause a seizure. But tranquilizers like benzodiazepines and barbiturates do the opposite. And so they're useful in the treatment of epilepsy, another major indication for benzodiazepines, as well as alcohol and sedative hypnotic withdrawal syndromes, any syndrome in which the risk of having a seizure is higher. These medications stop tremors and prevent seizures from too much out-of-control neuronal activity that we see in these conditions. Benzodiazepines are also muscle relaxers. They dull cognition, they interfere with short-term memory and can cause blackouts, anterograde amnesia for events following ingestion. These are all signs that GABA is attaching to and activating its receptor. There are a host of effects, really, and intoxication looks like being drunk. One is off balance, there's muscular incoordination called ataxia, there can be slurred speech called dysarthria, disinhibition, expansiveness, impulsivity, indiscretion, poor judgment, a personality change. There are people who habitually become angry and aggressive every time they get drunk on alcohol. We don't tend to see that with benzodiazepine intoxication. Benzodiazepine-induced aggression is considered a paradoxical reaction, affecting only a small minority of users. We more commonly see a seemingly paradoxical, agitated response in elderly patients with dementia. They get confused, and sometimes benzos exacerbate their disorientation, and then unassuaged fear or anger can lead to aggressive or violent behavior, especially in inpatient settings. We see that. Some medications, like barbiturates, such as phenobarbital, mimic the action of GABA. They're actual agonists at the GABA receptor. They have their own binding site on the receptor as well, but they bind to the GABA receptor and they stimulate it just as GABA would. So they're more dangerous in overdose because if you take enough pills, the end of that spectrum of obtundation is respiratory depression, coma, and death. You stop breathing. Your brain asphyxiates and you never wake up. Or if you're rescued in time, you wake up with brain damage. But benzos were a revolution when they were introduced because they're allosteric modulators of the GABA receptor. They don't directly stimulate the receptor themselves. They modulate it, meaning they bind, and benzos have their own dedicated site, just like barbiturates do, just like GABA itself has its own binding site, and they then modulate the receptor. The receptor, which is a transmembrane protein, a three-dimensional proteinaceous structure that actually forms a pore through which negatively charged chloride anions flow into the cell, hyperpolarizing it, making it less likely to fire. Again, quieting the nerves, numbing the neurons to stimulation. When Xanax binds, that receptor changes conformation. It undergoes a conformational change, which is a shift in the actual three-dimensional shape of that receptor, or else a shift in the flexibility or dynamics of the protein, increasing or decreasing the movement of certain segments of the protein. And when those changes occur, it increases the affinity of GABA for its binding site, the orthosteric site on that receptor. So Xanax and Xanax XR, or Valium, or Klonopin, or Ativan, or for that matter, non-benzodiazepines like Ambien, Sonata and Lunesta, the so-called Z drugs, bind to the GABA receptor. The receptor changes shape, and GABA, which is busily binding elsewhere on that receptor, does so with greater affinity. Benzodiazepines enhance the receptor's response to GABA by decreasing the rate at which the receptor unbinds GABA, leading to more frequent channel openings and thus greater inhibition of the neuron. And so we have increased frequency because GABA is not dissociating from its receptor. It's not letting go as easily. GABA exerts its effect to a greater degree, and a person calms down or gets sleepy or goes into a coma. Although again, benzodiazepine comas are much safer than phenobarbital comas. Benzodiazepines increase the frequency of channel openings, but barbiturates also keep the channels open longer, mimicking the action of GABA itself, which makes overdosing more dangerous. So there you have it, a somewhat simplified explanation. Yes, that's the simple version of the mechanism of action of benzodiazepines. All of that is identical for Xanax and Xanax XR. The pharmacodynamics, the way a medication interacts with the body's receptor proteins, i.e. the mechanism of action, are identical for those two medications. The difference is in the pharmacokinetics, how the substance is metabolized by the body. The half-life of the drug, defined as the amount of time it takes in hours for the body to clear 50% of the drug. That's what pharmacokinetics refers to, and it takes 5 half-lives to clear 98% of the medication. Now, the alprazolam molecule itself has but one intrinsic half-life. It's actually a range that varies from individual to individual, and even over time, but it's around 11 hours in healthy adults, and it can actually range widely from 6 to 27 hours, longer in elderly individuals or individuals with some form of liver impairment. The half-life of Xanax XR is likewise 10.7 to 15.8 hours, according to one source, i.e. 11 to 16 hours in most people. That's because the liver processes alprazolam the way it processes alprazolam. The XR is the delivery system. If you take 2 milligrams of immediate-release Xanax, you get most of that, whatever you absorb, all at once, and the effect of that all at once. Depending on your tolerance, you might fall asleep. But if you take 2 milligrams of Xanax XR, you get the same dose only over the course of 5 to 11 hours instead of 1 to 2. So the pharmacokinetics differ because of absorption, not metabolism. The half-life is unchanged when alprazolam gets to the liver, but the delivery system from mouth to bloodstream to liver is slowed. All other things being equal, of course. Various factors affect absorption apart from this delivery system. With physiological processes, we're always dealing with ranges. There are no absolute values, right? It's going to vary from person to person. Another variable, for example, is the time of day. Absorption is faster when medication is taken in the morning compared to at night. Food intake also affects absorption, not surprisingly. Interestingly, consuming a high-fat meal up to 2 hours before taking Xanax XR can increase the drug's plasma concentration by about 25%, despite the fact that whether or not it's taken with food doesn't affect the total amount of medication absorbed. We're talking about a 25% increase in the drug's highest concentration in the bloodstream, the peak concentration, despite the fact that over time we get about the same total absorption. Now here's an important difference between the formulations. In contrast to the XR, a high-fat meal actually reduces the peak concentration of immediate release Xanax by about the same amount, 25%, even though, again, the overall absorption is unchanged. Food delays the time that it takes to reach that peak concentration, especially fatty meals, because fat in the stomach delays gastric emptying time so that you don't dump all of your fat into the small intestine at one time and overwhelm your poor gallbladder. This effect is negligible for Xanax XR because Xanax XR has a controlled release, it produces less of a spike anyway, and instead maintains fairly constant blood levels over many hours, 5 to 11. So a fatty meal appears to alter the controlled release of Xanax XR in such a way that it creates a higher peak concentration, whereas when the immediate release is taken with food, the drug's absorption is slowed, which delays and lowers the peak concentration of that molecule because of the way that it is absorbed and the way it peaks. I hope that's clear. And the person's individual metabolism always matters. Factors such as the person's age, weight, liver function, and race, i.e. genetics, can influence the rate at which the body processes and eliminates medications. And finally, other concomitant medications. Certain drugs, such as those that inhibit the cytochrome P450 enzyme system, and in particular CYP3A4. Drugs that inhibit the CYP3A4 enzyme in the liver can slow down the metabolism of Xanax, which obviously causes it to remain in the body longer. Xanax is FDA approved for generalized anxiety disorder, the immediate release preparation, but both preparations are approved for panic disorder. However, psychiatrists and clinicians use it in all types of anxiety disorders, as well as major mood disorders with anxiety, such as major depression with anxious distress, as well as PMDD, premenstrual dysphoric disorder, and other conditions that feature anxiety prominently, phobias and whatnot. Benzodiazepines are also the treatment of choice for catatonia. Please see my I Was Catatonic and Lived to Tell About It video for fascinating insights into that symptom. Where in the brain is Xanax effective against anxiety? Well, it's active everywhere, of course, but the area of the brain that's affected when you get slurred speech, Broca's area, is different from the neurons in the hippocampus that are implicated in blackouts. So with anxiety, in the most general terms, we think the hotspot in the brain is the amygdala and associated limbic system structures. More primitive areas of the lizard brain involved in the fight or flight or freeze phenomenon. Structures which are responsible for basic survival instincts, which makes evolutionary sense. What's a typical dose? It depends. It depends on the target symptom and it depends on tolerance. For anxiety, lower doses. For insomnia, much higher doses. And you often have to titrate the dose, and then you can end up in a lot of patients with resistance because after a while, they're just not sedated at all on whatever dose you're giving them. And you can't continue to increase it because of the risk of withdrawal, which can be life-threatening. But there are strategies. Please see my How to Make Your Sleeping Pill Keep Working video for more information on that. The immediate release can be dosed anywhere from 0 milligrams when the medication is being prescribed as needed only. And I always encourage my patients not to take doses if they don't absolutely need to. So please remember that, guys. 0 is the low range for the immediate release anyway. And then beginning with 0.25 milligrams, a quarter milligram, on up to, officially up to 4 milligrams a day, typically in divided doses throughout the day at the higher end of that range, unless we're using it to treat insomnia, and then you get the bulk of that dose at bedtime. And I tell my patients to take whatever they're going to take, whatever they need, however many milligrams they need to fall asleep and to stay asleep, and they need to take it all at once, preferably on an empty stomach, right before they get into bed, 20 minutes, not hours and hours before. So I've got another video on that. But I tend to shy away from using alprazolam for sleeplessness because a lot of patients complain of difficulty arising the next morning. Despite being known for its short half-life, that's a frequent complaint clinically, that it's hard to wake up the next morning. I hear that a lot with Xanax for whatever reason. The XR dosing range is 3 to 6 milligrams a day typically, although lower doses are frequently possible and, again, always encouraged. XR is taken at the start of the day as a scheduled dose, typically, meaning routinely, and it's dosed once. The capsules are supplied in doses up to 3 milligrams, 0.51, 2, and 3 milligram capsules, so the maximum dose would require 2 capsules taken at once. The denominations of immediate release Xanax are 0.25, 0.51, and 2 milligram bars, the famous Xanny bars, which is a common terminology among recreational Xanax users. In fact, when I hear a patient call them bars, it's usually a red flag. Among other agents in this class, Xanax is very popular with recreational benzodiazepine users. See my Everybody's Favorite video. And also, please check out my 2-part series on the benzos for more. In Japan, there are 0.4 and 0.8 milligram denominations of the immediate release as well. And there's an immediate release alprazolam solution, 1 milligram per cc for those individuals who have difficulty swallowing pills. That's available everywhere. Now, the reference I use claims that the maximum daily dose of Xanax might approach 10 milligrams, which I think is just a humongous dosage. So I'm going to disagree here with my colleagues over at NEI, the Neuroscience Education Institute. In my experience, while patients certainly develop tolerance to the sedative effect of benzodiazepines, they generally do not develop significant tolerance to the anxiolytic effect. And at any rate, even for insomnia, I would never prescribe 10 milligrams a day. I personally. Doses that large are certain to backfire. Rebound symptoms can be severe, including panic or even seizures. And few patients can take such high doses responsibly, in my opinion. Okay. Not to mention the cognitive dulling, sexual dysfunction, and other side effects that just wouldn't justify such a very high dose in most people. Difficult cases would obviously also be managed with a serotonergic agent, an agent that increases serotonin, such as an SSRI, the gold standard, actually, and possibly other adjunct medications. A lot of times, adding a dopamine partial agonist works wonders. Please see my Abilify, Vraylar, and Rexulti videos. Whatever else, we always employ a benzodiazepine sparing strategy. We use the lowest dose for the shortest feasible period of time. Although with endogenous anxiety syndromes like generalized anxiety disorder, panic, and social anxiety disorders, those conditions are lifelong and can be put into remission so long as a person takes medication, but they're not curable otherwise. Despite the safety profile of benzodiazepines compared to barbiturates and other sedatives, fatality is possible in overdose with monotherapy. That is, a pure Xanax overdose. You can take enough to stop breathing and die. But since you're just potentiating endogenous GABA, as I explained earlier, and there's only so much endogenous GABA around, it's not like GABA mimetic medications that directly open those chloride anion channels and keep them open. It's much easier to give a lethal dose of a medication that doesn't need endogenous GABA to shut down neurons in the brainstem. But benzodiazepine overdoses, fatal benzodiazepine overdoses, are uncommon, at least compared to those that involve combining benzos with alcohol and other sedatives. That's much more dangerous. Those are very common. It's very, very common that a person will take a benzodiazepine and they do die, but it's because they combined it with alcohol and other downers. With alcohol, individuals often vomit and choke on that. They don't stop breathing due to central asphyxiation necessarily. You would really have to have pretty large doses of sedatives and alcohol to accomplish that, but their airway gets clogged and they have no cough reflex and they're unconscious and they asphyxiate that way. That's why you should always turn a drunk, unconscious person on their side, or really just any person who has overdosed on a sedative hypnotic agent, turn them on their side, but especially alcohol because vomiting is very common. It's called the recovery position. Minor overdoses look like alcohol intoxication: dysarthria, imbalance, ataxia, which is muscular incoordination, confusion, a clouded sensorium even, which is essentially delirium. The only difference is that when you're intoxicated, it's not waxing and waning. You're not going in and out of it. That would be the only difference. But you also see diminished reflexes, and later on, if you take enough, amnesia, which again is the anterograde variety. Individuals don't forget the stuff they did before they took the overdose. It's what comes in the aftermath that's not recorded. And of course, disinhibition, expansiveness, and poor judgment. Expansiveness is being open and friendly, talkative, unrestrained in the expression of feelings, the opposite of introversion. When inappropriate, it's a sign of either intoxication or mania or dementia. I mean, there are a few other things it could be. People on the methamphetamine drug ecstasy, MDMA, are famously touchy-feely, literally draped over one another in the stereotypical example. When one is talking too much and revealing personal and potentially embarrassing information, or is asking invasive, inappropriate questions of others, one is expansive. You just want to meet everybody. Every stranger is your friend. When you see people proselytizing on the street, a lot of times it's because they're either high or they have bipolar disorder or both. The caricature is that of the lampshade on the head life of the party. Paradoxical agitation and aggression are also possible, especially in the elderly demented and patients with primary psychotic disorders. Really, it's uncommon otherwise. So there you have it, a brief rundown of the two kinds of alprazolam. Thanks for watching, and as always, questions and comments are welcome.